Welcome to The Critical Edge, the no-nonsense podcast breaking down the latest game-changing evidence in trauma and surgical critical care to give you the edge when things get critical.
It's great to be here for another deep dive.
Yeah, and today we are tailoring this deep dive specifically for you, the U.S.-trained trauma and surgical critical care surgeon.
Right, because our mission today is really to, extract the absolute most vital clinical pearls from the literature.
Exactly. We're going to fiercely interrogate the statistical methodologies behind 4 cutting-edge papers and evaluate their practice-changing implications.
I mean, we're covering a lot of ground. We're going deep into aortic occlusion, hemodynamics, the kind of deceptive physiology of solid organ management.
That one's huge.
Right, and the shifting paradigms in blunt thoracic trauma, plus the brutal systemic logistics of pre-hospital transport.
It's a massive stack of data today. Okay, let's unpack this, because we're moving from, multinational pooled registries analyzing endovascular interventions literally down to the millimeter of mercury to geospatial analyses mapping urban transport times.
And interpreting all these disparate data sets really requires ruthless critical thinking. Because you, the surgeon standing at the bedside, you have to translate this population-level predictive modeling into split-second decisions.
The moment those EMS doors fly open. Right. So we're starting right in the resuscitation day with the most hemodynamically catastrophic patients.
The ones that really test you.
Exactly. We are tackling the perpetual, hyper-debated controversy of when exactly to deploy your REBOA.
It's basically the quintessential double-edged sword.
Right, because for the last decade, we've treated aortic occlusion as a salvage maneuver, but the precise physiological trigger has always been, highly subjective.
Yeah, I mean, occlude the aorta too early, and you subject the patient to a devastating ischemia-reperfusion injury, right?
Yep.
Catastrophic lactic acidosis, potential mesenteric necrosis.
But if you wait too long, you just lose the patient to irreversible cardiovascular collapse. So we're looking at a 2024 paper by Ordonez and colleagues.
Yeah, this is a massive multinational pooled analysis. They merged the ABO and the AST aorta registries and captured data all the way up to 2021.
And the explicit objective here was finally pinning down the optimal pre-deployment systolic blood pressure threshold,
which we've desperately needed. They analyzed 848 patients, and notably, they excluded the patients who arrived with an SBP of 0 and stayed at 0.
Right, the true dead on arrivals, which is critical for avoiding extreme survivorship bias in the data.
Exactly. Roughly 20% of this cohort suffered penetrating trauma, and the overall 24-hour mortality was a staggering 32%.
Which immediately grounds us in the reality of just how sick this cohort is. But what elevates this paper from a standard retrospective review is the statistical modeling.
Oh, man. What's fascinating here is they didn't just run a standard linear regression. They utilized fractional polynomials to plot the probability of death against the pre-deployment SBP.
Wait, translate that for us. Because a lot of surgical literature falls into the trap of forcing linear relationships onto nonlinear human physiology.
Right. Well, if you use a standard linear regression, the math just assumes that as blood pressure goes down, mortality goes up in a perfectly straight line.
But we know from managing hemorrhagic shock that human hemodynamics don't behave like a straight line. I mean, they behave like a cliff.
Exactly. You have a prolonged period of compensated shock where the catecholamine surge maintains the pressure, and then, boom, a precipitous catastrophic drop.
So these fractional polynomials?
They allow the statistical model to bend, to flex and actually fit the real shape of the physiological data without presupposing a straight line.
Oh, wow. So when they applied this to the 848 patients, what did the graph look like?
It wasn't a linear slope at all. It created a distinct, mathematically validated U-shaped curve.
A U-shape, meaning there is a definitive trough where the probability of death hits its absolute lowest point.
Precisely. And the bottom of that U-shape sits squarely between a pre-deployment systolic blood pressure of 60 and 90 millimeters of mercury.
Is an SBP of 60 to 80 essentially the Goldilocks zone for REBOA? Not so high that you don't need it, but not so low that the patient is already too far gone.
That is a perfect way to look at it.
Okay.
Because if you drop below 60, the multivariable Poisson regression analysis shows the relative risk of death skyrockets by over 50%.
Wow, a 50% jump.
Yeah, the relative risk was 1.5, with a highly significant p-value of 0.001.
So mechanically speaking, if we think about the cardiovascular system as a closed-loop hydraulic pump, if you wait until the SBP drops below 60, you've essentially encountered pump cavitation.
The right heart has just entirely lost its preload.
Right. The venous capacitance system is entirely empty. At that point, inflating the balloon in the aorta does absolutely nothing because there is no volume left to push up into the coronaries or the carotids.
The pump has lost prime. You're watching the physiological window of salvageability slam shut.
Conversely, if you deploy when the systolic is riding high, say at 110, you are prematurely dead-ending a system that is still compensating.
You're drastically increasing the afterload, blowing out the left ventricle, and inflicting massive downstream ischemia.
You're trading a manageable hemorrhagic shock for a lethal ischemia reperfusion cascade.
Right. The washout of reactive oxygen species when you finally deflate that balloon can be just as lethal.
But I have to push back here on the utility of a single SBP reading.
Well, let's hear it.
We both know that in the chaos of a trauma resuscitation, a non-invasive cuff pressure can be wildly inaccurate. Even an art line can be damped in the first 5 minutes.
Sure.
So is a single SBP reading of 70 really a robust enough trigger to commit to total aortic occlusion?
That's a really vital critique. And the authors actually anticipated it. They looked at the area under the receiver operating curve, specifically for SBP, as an isolated predictor of mortality.
And what was it?
The AUC was only 0.599.
Wait, that is barely predictive.
Right.
I mean, an AUC of 0.5 is a coin flip. 0.599 is a mathematically weak discriminator for a standalone diagnostic test.
It is, which completely proves your point.
Yeah.
You cannot treat the monitor's number in a vacuum. It isn't a perfect crystal ball.
So how do we use it?
Well, they applied formal cut point testing to find the exact zone of maximum discriminative ability. Yeah. And that pinpointed the 50 to 70 millimeter mercury range as the starkest physiological divide between salvageability and futility.
Got it. I also want to aggressively challenge the retrospective nature of this data. We are looking at a massive confounding by indication here.
Yeah, the survivorship bias is definitely the glaring limitation of this paper.
Right, because we have absolutely no control group of non-REBOA patients. Would those patients with an SBP of 60 to 80 have survived without the balloon, just with MTP and immediate laparotomy?
We simply don't know based on this specific data, and combining blunt and penetrating mechanisms with only about 20% penetrating really skews us toward blunt physiology.
Plus, they combine Zone 1 and Zone 3 deployments. Inflating a balloon above the celiac axis for a shattered liver is a profoundly different insult than a Zone 3 balloon for an iliac avulsion.
It absolutely is.
Yeah.
But despite the limitations, we have to extract the actionable clinical pearl for the listener.
Which is, if you're standing at the bedside, the MTP is running, and you're watching the systolic slide from 90 to 80 to 75.
Deploying REBOA when the SBP hits that 60 to 80 window might prevent complete cardiovascular collapse.
Anticipate the failure, don't just react to it. Okay, let's smoothly transition our focus. Speaking of anticipating failure,
Let's do it.
we just discussed deploying a drastic mechanical intervention. Now we're transitioning to deciding when not to intervene on a solid organ injury that is actively bleeding.
Right, the intensely uncomfortable discipline of sitting on your hands. We're diving into a 2024 paper by Spoor and colleagues out of East.
This is a multi-center study of 21 institutions from 2014 to 2019, right?
Yeah, and they wanted to analyze the failure rate of non-operative management NELM in hemodynamically stable adults with blunt splenic injuries.
But specifically, grade 3rd and grade 2 injuries that exhibited a contrast blush on the initial CT scan, meaning active extravasation.
Exactly. They looked at 145 patients, and the overall failure rate of NM in this specific cohort was 20.0%.
Wait, a 20% failure rate for a supposedly low-grade injury? That's clinically unacceptable.
It completely upends the traditional safety profile.
Okay.
And statistically, there was no significant difference between the failure rates of grade the first, which was 18.2%, and grade the second, which was 21.1%.
The p-value was greater than 0.05, right? So the structural depth of the laceration was entirely irrelevant if there was a blush.
Irrelevant. You have to break down the bivariate comparisons for those who failed observation.
What happened to them?
They suffered increased median hospital length of stay, a higher need for blood transfusions, and significantly higher rates of massive transfusion protocol initiation.
With a p-value of 0.030 for the MTP, I think. So if 1 in 5 of these patients fail, and they end up needing massive transfusions, why are we calling these low-grade injuries?
That's the real issue.
Isn't that like calling a leaky gas line a minor plumbing issue just because the pipe is small?
That analogy perfectly explains it. You're actively resuscitating the patient, raising their blood pressure, which increases the hydraulic pressure directly against that fragile pseudoaneurysm wall.
And when does it blow out?
Importantly, 69% of those who failed did so within the first 12 hours.
The first 12 hours. So the clot retracts, systemic blood pressure normalizes, the capsule distends, and it just ruptures.
Exactly.
Yeah.
Now, to understand why a 2024 paper is analyzing 2014 to 2019 data, we have to look at the AST organ injury scaling.
Right, because before the 2018 AST spleen injury scale update, a blush wasn't a primary grading factor.
It was almost purely structural. The 2018 update correctly recategorized vascular injuries, like a blush, as grade 4th, or V.
So this paper basically proves the necessity of that update. It shows that a blush on a structurally grade I spleen behaves exactly like a high-grade injury.
It absolutely validates it.
So the clinical pearl for the listener here is, do not be lulled into a false sense of security by a structurally small splenic laceration if there is a contrast blush.
Early angioembolization or surgery should be strongly considered because 20% will fail observation, usually within that first 12 hours.
Treat the vascular physiology, not the anatomical topography. Okay, let's keep moving. We just saw that low-grade injuries in the abdomen might require more intervention.
Right.
Now let's look above the diaphragm at the aorta, where low-grade injuries might actually require less intervention than we thought.
This is a massive paradigm shift. We're looking at a 2024 paper by Golestani and colleagues using the Aortic Trauma Foundation Registry.
From 2016 to 2021, and the objective was to compare outcomes of NOM versus thoracic endovascular aortic repair TAVR for grade SF intimal tears and grade 2nd intramural hematomas.
They identified 269 patients. 81% were managed with M and 19% with TAVR.
Here's where it gets really interesting. If you look at the unadjusted numbers, the mortality was 8% for the nonoperative group versus 18% for the TAVR group.
And with a p-value of 0.009, that looks really bad for TAVR.
A superficial reading suggests that putting a stent into a low-grade aortic injury more than doubles the risk of killing the patient.
Right, but this raises an important question about selection bias. The TAVR group was inherently sicker on arrival.
How much sicker?
They had lower admission, SPP 114 versus 124, and a much higher need for laparotomy, 31% versus 15%.
So these weren't stable patients with isolated bruised aortas. They were crashing polytrauma patients.
Exactly. The overwhelming systemic burden of injury was killing them, not necessarily the TAVR. So the authors applied a multivariable regression model.
Controlling for age, sex, SBP, ISS, GCS, and laparotomy, right?
Yes, and when they mathematically adjusted for how sick the patients were, the difference mortality vanished. The odds ratio was 0.82, spanning 0.25 to 2.67.
So there's absolutely no statistically significant difference in survival once you level the playing field.
Exactly.
But wait, if the adjusted mortality is the same, why take the immense risk of putting a rigid metallic stent into an aorta that essentially just has a bruise?
You're introducing a whole new set of morbidities. Access site, vascular complications, spinal cord ischemia, stroke. It's not benign.
Isn't the best surgery sometimes no surgery at all?
I completely agree. And while we have to note the limitation that this isn't a randomized controlled trial, the retrospective data strongly suggests true clinical equipoise.
And this mirrors the East Practice Management Guidelines for blunt aortic injury, doesn't it?
Yes. This new data heavily supports the modern shift toward medical management. We're talking strict heart rate and blood pressure control.
Anti-impulse therapy, decreasing the kinetic energy slamming into that fragile intramural hematoma.
Exactly, sparing patients the potential morbidity of TAVR.
So the clinical pearl for the listener. Medical management alone is safe and not inferior to TAVR for low-grade blunt thoracic aortic injury. Save the endografts for your grade 3rd and 4 injuries.
Less is definitively more when the intimae is intact.
All right, that brings us to our final segment. We've spent this entire deep dive heavily entrenched in the weeds of physiology and operative decision-making.
We really have.
But all of these highly advanced interventions, the REBOA, the angioembolization, the TAVR, they are utterly useless if the patient doesn't reach your trauma bay in time.
We're shifting from intravascular physiology to urban geography. We're looking at a 2024 paper by Polson and colleagues.
They mapped Boston Police Department data using ArcGIS software from 2005 to 2023.
A massive time frame. The objective was to examine the relationship between transport times, victim demographics, and ultimate mortality in gunshot wound victims.
And the data set is huge. 4,545 victims, 758 deaths.
And the most sobering statistic centers entirely on transport time. The median transport time for survivors was 9.4 minutes. For non-survivors, it was 10.5 minutes.
With a p-value of 0.003, a difference of barely 60 seconds.
Yes. Multivariable logistic regression showed transport time was independently associated with mortality, with an odds ratio of 1.024 for every single minute increase.
So every literal minute counts.
Every minute. And
Okay.
then you have to look at the median transport times by demographic groups, and the disparities are glaring.
Let's hear the numbers.
Non-Hispanic Black victims were at 10.1 minutes. Black Hispanic victims were 9.2 minutes. White Hispanic victims, 8.5 minutes. And non-Hispanic white victims, 8.3 minutes.
And that's highly statistically significant, p less than 0.001. But I want to rigorously challenge the methodology here because these are GIS predicted times, not actual EMS runtimes from a PCR.
That's a known limitation of geospatial research, absolutely.
So how do we know this isn't just a mapping artifact? How does this account for traffic or an EMS unit that happened to be staged nearby?
Well, the authors utilized a highly sophisticated statistical tool called a spatial autoregressive logit model.
Oh, what? Break that down.
Sure. In classical stats, we assume data points are independent. But geographically, a shooting on one block is highly correlated with outcomes on the next block.
Right, they share the same physical infrastructure.
Exactly. It's called spatial autocorrelation. This specific model mathematically controls for the tendency of geographically clustered areas to share similar outcomes.
That makes the findings exponentially more robust. It strips away the ambient noise.
It does. And they simulated setting all transport times to the white non-Hispanic median of 8.3 minutes and found a modest but very real hypothetical decrease in overall mortality.
If we connect this to the bigger picture, the heat maps basically show that definitive trauma centers are geographically misaligned with the actual epicenters of firearm violence.
Mostly in the southern part of the city, yes.
I want to be extremely clear for our listeners here. We are evaluating these demographic and systemic findings purely as factual, objective data points that affect surgical outcomes.
Absolutely. We are analyzing the data strictly as presented by the authors to understand trauma system logistics without endorsing any political viewpoints.
Because from a physiological standpoint, physical distance equals transport time, and transport time equals unchecked hemorrhagic volume loss.
The physiology of exsanguination does not care about city planning.
So the clinical pearl for the listener, advocacy for intelligent trauma system design is as critical as your surgical skill. Where trauma centers and EMS stations are placed dictates the physiological state of the patient rolling through your doors.
You have to look beyond the individual patient on the table.
Okay, we've covered a massive amount of ground today, looking at the REBOA thresholds, the splenic blushes, the aortic injuries, and the transport times. What is the unified takeaway for the U.S. trauma surgeon listening right now?
The unifying theme is just time and triage. Whether it's the 60 to 80 SBP window before right heart failure, the 12-hour window where 69% of splenic blushes fail, or the 60-second difference between a 9.4 and 10.5-minute transport time.
Anticipating failure rather than merely reacting to it.
Exactly.
Mm-hmm.
Modern trauma care requires anticipating the physiological collapse long before it happens.
Let's summarize our clinical actions. 1. Target an SBP of 60 to 80 for REBOA candidates to catch them in that optimal window. 2. Categorically treat grade 1 and 2 spleens with a contrast blush as high-grade injuries requiring early intervention.
3. Utilize medical management for grade 1 and 2 blunt thoracic aortic injuries.
And 4. Recognize the profound impact of pre-hospital transport inequities on the baseline physiology of your patients.
Implementing these concepts is what gives you the edge.
I want to leave you with a final, provocative thought to mull over. If a patient's zip code and demographic profile reliably dictate their transport time, and we know that transport time dictates their mortality risk upon arrival, shouldn't our predictive models and our massive transfusion protocols automatically adjust their activation algorithms based on the geographic location of the injury?
Anticipating the need for massive products before the patient even crosses the threshold.
Exactly. Okay, let's wrap this up. Keep dissecting the data, keep questioning the guidelines, and we'll see you on the next deep dive.